first, what I want to tell you guys a little bit about is what we think about when we're doing an exam in terms of etiquette. So, what do you see when you're doing this? Number one, as you can see, I've chosen to put a wall behind me. It's simple, it's non-distracting, and especially for our headache patients, you don't want any bright lights shining in their face. You want to make sure that it looks professional as well. So I'm not sitting here in my sweats, even if I was home. You want to look like it's the professional interaction that they would expect in a clinic. You also want to try to turn off all notifications. For instance, right now, if people are messaging me, I have a little ding going off. So in future, if I was using this computer, I would want to make sure I figured out a way to turn that off so that's not coming through. Finally, as a really important part of your setup, you want to consider sound so they're able to hear you. And number two, what are you looking at? Right now, all I have is the image of me and then your guys' comments to the right. So looking straight ahead is a little bit simple. But let's say the picture of me was down in the corner. I would continually be looking like this. So you guys actually wouldn't see proper eye contact. So one trick is put some little googly eyes right up there by your camera so that it gives you some prompt to keep looking, because you do want to try to optimize that you're doing some really good eye contact. Next, think about lag. So while this is a synchronous medium, there is going to be some delay. A really good rule is if a patient's talking, give them about 2 seconds before you jump in so that you're not interrupting them. If you're going to look away, like let's say I wanted to make some notes, tell the patient what you're looking away for, because otherwise it just looks like I'm being rude and maybe I'm playing on my phone. So you want to give them a heads up. Hey, I'm just looking at the EMR right now just to check something. I want to see if that was what your exam showed when I saw you last time, etc. Another really important thing to consider is patient safety. So if you are seeing someone who is alone, especially if they're elderly or frail, if they have any mobility issues, let's say they have vertigo, if you're going to get them up doing some sort of exam where they're standing or moving, think about their fall risk. The best way would be for those patients to have a family member or a friend with them to make sure that they're safe. But if you're going to have them upright and you feel that it is safe to do so, then make sure they have something like a couch behind them when they're doing something like the Romberg, or a wall behind them, so that if they do fall, they're not going to fall onto the ground. And it is really helpful anyway to have a family member around, because they might be able to help you with some of the features of the exam. Plus, if you want to use some tools from around the patient's house to assist you with the exam, they can run and go get them for you. Finally, a really important part is make sure you reassure your patient. A lot of them are going to be new to this telemedicine, just like all of us, and it's going to be a little bit nerve-wracking. They're going to be worried, are you actually going to be able to pick up something to make sure that I don't have a scary headache? What if I have a brain tumor? How are you going to rule that out? The good news is the majority of our physical exam is actually a really reliable tool that we can do through telemedicine. There are a few things that we just can't check, and I'll go through those, but overall you can check them, and you can let the patient know this, that through what you tell me and through most of what I'm able to do, we can actually rule out the really scary things. All right, so let's get into the physical exam. Number one, vital signs. Normally when the patient comes into clinic, either the physician, the nurse, your medical assistant, someone is going to be taking some vital signs for you. Obviously, when you're doing this, that's not possible, but most patients have a thermometer, many patients have a blood pressure machine, and a lot of patients have a scale. So you actually can check things like temperature, especially if you're particularly concerned about it. If it's a patient where you do want to know something about their blood pressure, or if the blood pressure machine checks their heart rate, you can check those things. And if you're wanting to follow something like their weight or their BMI, especially for a patient who has something like IIH, then that's something that you can actually ask them to check and then record it. You can also always comment on their overall appearance. So for instance, if they're sitting there in the dark, they're wearing their sunglasses, they have ice packs on their head, they're very clearly uncomfortable, you can actually comment that this patient's in distress from pain. Or are they sitting there like this, they're having good conversation, they're able to hear you, they're responding appropriately, then again, you can comment on all of those things. All right, so let's get into next, the first part of the major aspects of physical exam for neurology. Mental status. Mental status is no different than if you were in the clinic. A formal mental status exam should comment on speech. So what is their rate? What's their volume? What's their articulation? Is that all appropriate? What's their thought process? Is it sequential and coherent, or are they really tangential? How are they doing with associations? Are they having a lot of loose associations? What's their thought process like? Are they having hallucinations? Are they having delusions? Are they having suicidal ideation? You can have them tell you what their mood is, and then you document it as such. And you can also comment on their affect. Is it appropriate? Have they been going through a really hard time and they're tearful, but it's appropriate to the situation? Do they have appropriate insight and judgment that appear to be intact? And then you can tell for cognition, are they giving you an appropriate history and they're able to have good recall? You can formally test it. So if you have someone where they're having progressive headaches and you're worried about changes in cognition, then you could pull out something like the MOCA or the MMSE, and you can walk them through that exam process. They're going to need pen and paper, and you will need some big blow-ups of some of the things that they need to copy. You won't be able to do something like, say, the trails, but the rest of the exam, for both of them, you can actually perform. All right, so cranial nerves. Obviously, we can't do fundoscopy. That is the number one biggest limitation to doing a telemedicine exam. If you are really worried about someone having increased ICP and someone who's actually losing vision, that's someone who needs to be assessed more urgently. And even in light of COVID-19, there is, some way that you hopefully can get them seen, and make sure you're monitoring them and keeping a close eye on that patient. And you should get them in as soon as possible to actually check their vision. If you have access to fundus photos or OCT or even formal visual fields, that's another option that you would be able to actually do. So what about the rest of cranial nerve too? So number one, what's the patient seeing subjectively? Have them cover one eye. What do they see? Have them cover the other eye. What do they see? Some ways that you can really try to get a little bit better assessment. So let's say you're worried about them having some sort of optic neuropathy as part of a process. So you can check red desaturation. Most of us have something like a red pen. What do you see with this eye? What do you see with the other eye? You can comment on those. The stroke cards are a really great source. If I can get the paper. So you can show them something like the NIH stroke score paper. Note that holding a paper up is kind of difficult. If I'm having it here, I can't actually see where it is. It is hard to hold it up. So you do want to kind of peek over while you're doing it. Get it about centered. And then you can ask them to look with one eye and then the other eye and have them tell you, say, how many people are in the photo? If they say just two, maybe they are just seeing these two people. So are they having a visual field defect where they're missing this person? Are they having neglect? So that's a good way to assess it. You can also use some of the sentences that we see. So have them read them across. If they're having a difficult time seeing all of the sentence, then again, maybe they have a part of their visual field that's missing. You can attempt to test visual field. So if they're looking straight ahead with one eye and you're telling them looks forward, you're going to need a very compliant patient for this. Think about dividing your screen into 4 parts. So if you try to hold your fingers, you can kind of do it, and you're going to have to figure out how to hold your fingers. It's a little bit awkward, but you can try to do that. You could even do visual extinction if I can get my fingers right. So can they see all 4? It's hard to do. It takes some practice. As you can see, I'm a little awkward doing it, but if you really need to check it, it is something you can attempt. You can also have them do the line bisection test. So with some paper, have them draw a straight line and then draw a vertical line through it and see if that looks like it's centered. Finally, you can actually do pupils. So if I come really close, and there are going to be some entertaining parts on this video of me, so feel free to laugh. If I come nice and close, luckily I have blue eyes. So your patients with blue eyes, it's going to be way easier. If I close my eyes really tight and then open them, you should be able to see that my pupils constrict. And a lot of patients actually are going to have something like a flashlight. Again, if they're up close and they shine the flashlight, you should be able to see that their pupils are constricting. So you can test that. You're not going to be able to do an RAPD. It might be a little bit tough, but in general, you can check those. So, do they have one pupil that's really asymmetric, and do they have a ptosis with that side? Okay, well, maybe then you can be worried that you're actually dealing with a Horner's. If they have a really big asymmetry and a blown pupil on the side, and, they're having other signs of IIH, well, then you're worried that you probably should be checking the opening pressure and getting a lumbar puncture. Next, you can actually check eye movements. So again, have them nice and close to the camera, and you can comment on their eyes in primary position. So you should see that, I don't have any esotropia or exotropia, at least as far as I can tell. And you can tell them, look up, look down, look right, look left. And as you can see, you can actually see the full range of my eye movements. Now, it's not going to tell you about if their smooth pursuit is normal. It's not going to properly tell you about saccades. You can look for nystagmus, so you can at least comment on the lack of nystagmus. So it's going to give you a pretty decent assessment of that. Now, for cranial nerve 5, check, just in general what their subjective is. So let's say someone's coming in with trigeminal neuralgia, It's on this side of their face. They say the pain's here. Well, you can ask them, do you have any numbness or tingling on that side? Like when you touch, does it make it feel tingly? So they have dysesthesia. Is there an area where you're feeling numbness? They can be like, yeah, actually, I kind of have numbness in this area right here. So have them draw it out with their finger so you can at least document and describe it. If you want to get a bit better assessment, maybe see if they have some ice. They can touch on either side of their forehead and can tell you, this side feels cold, but I'm only feeling about 50% of the cold here. Or actually, it doesn't feel cold. It feels warm on that side. Or maybe it's painful to touch. And then you can also look at jaw movement. So can they open their jaw fully? Are they telling you that they're hearing any clicking or cracking or popping when they're doing it? Is their jaw getting caught? You might be able to see their masseters. It's going to be a little hard to comment, but if they have a major asymmetry or there's clearly something abnormal, like they have a jaw deviation when they're opening, you can comment on those things. Because remember, the jaw and TMD can be part of actually a headache presentation. Cranial nerve 7 is going to be just the same as you do in the clinic. You're going to look at their their forehead elevation. You're going to look at whether or not they can close their eyes tight. Can they show you their teeth, their platysmouth? You can do all of those things. So that's not going to be any different. For cranial nerve 8, at the very least, you can comment that it's intact to voice. So they are at least hearing you during this audio visual. If they have a family member there, they could test finger rub on either side for you and tell you if there's any asymmetry there. For cranial nerve 9 and 10, comment on if there's any dysarthria. And another entertaining part of the video for me, you can get up nice and close. You can see that my palate elevates. It's better if they have a light so you can see in there. Some cameras actually have a zoom feature so you can see it a bit better, but at least attempt it. You can probably see the palate enough to comment on it. You can do shoulder shrug, head rotation. So you can do all of those things to try to comment on cranial nerve 11. And then for, again, cranial nerve 12, I can stick my tongue out. There's no atrophy. There's no fasciculations. So you can look at all those things. All right, so next we're going to be talking about the motor exam. This is a part I think a lot of people worry about outside of fundoscopy. So you can comment on bulk. You can comment on if there's fasciculations. Let's say someone's coming in with a stroke and they have a flexion contracture. You can comment on that. If someone's doing gait and you actually see that they have spastic tone, then you can comment on that as well. You're not going to be able to formally attest the tone though, of course. With strength, okay, so you're not going to get your full MRC rating scale, but you can do pronator drift. Are you seeing an asymmetry? You can do arm roll. You look for the satellite sign where the strong arm satellites around the weak arm. You can do the NIH stroke score for strength. So are they at least anti-gravity? Do they have a 5-second arm drift? You can do that for leg. Are they at least anti-gravity? Do they have a drift within the 10 seconds? If you want to get a little bit more with the leg, have them move further away from the camera. See if they can do squats. Can they jump on one leg? Can they heel walk? Can they toe walk? If they can do all those things, they're probably pretty strong. If you're someone, if you're seeing someone who's like a big, strong bodybuilder and you're thinking, they're not going to have a drift in their arm, but I am a little bit worried about their strength, have them see if they can do some push-ups. If they can do push-ups, they're probably pretty good. Again, you can't rule out, but that's a pretty good sign. Now you can comment on tremors. You can comment on bradykinesia. You're really not going to be able to comment on reflexes unless someone blatantly has some clonus or something that they get just by moving their ankle. The reflexes just aren't going to be a useful way to test. The reality is most of the time, we're expecting those reflexes to be abnormal. I think it's pretty rare that I see a patient where I am surprised by an abnormal reflex. So it is rare that I think that's going to be something that you have to be significantly worried about. If you really are concerned that you want to test for some sort of upper motor neuron sign, if they have a family member there, you can get them to take something, show them your hand and tell them on the side of the foot, on the outside, you're going to draw up and then draw across the ball of the foot. And you're going to have them do that so you can actually see the foot, and you can try to see if there is an upgoing toe. Again, it's not going to be as reliable, but if you are really concerned, you can do that. And again, if you're really worried, find a way to have the patient assessed urgently. For sensory exams, similar to how we would do trigeminal nerve, if they're saying, every time I move my neck, I've got something that's shooting into my arm. Okay, well, do you have any numbness, tingling? Yeah, it's kind of in this area. So have them draw it out and you describe it. Again, you can test with the ice on either side. If you're doing pronator drift and you see this sort of drift up, that's a sensory drift. That can be a problem with proprioception. Have them do Romberg if you feel it's safe, and that's going to test for proprioception in the legs. Another thing is you can check to see if they have anything where you're worried about, say, a radiculopathy. So if you have them tilt their head and tilt it to the side, is that causing shooting pain into the arm? What about tilt to the other side, shooting pain into the other arm? So you're essentially testing a Sperling's by doing that. All right, so now we're getting into coordination. Obviously, you can't do finger to nose unless you want them to actually reach, touch your nose, and go to their nose. You could do that. Another thing is you just have them stretch their arm out, touch, touch. I mean, you can very clearly see I don't have dysmetria. You can have them do rapid alternating movements or just tapping really fast. You can do heel to shin, and the way you're going to do that is tell them to bring their leg up where you can see it, take their heel and bring it along their shin, and you're going to be able to test again, do they have any dysmetria with that? You're going to want to test gait and tandem gait unless you think it's unsafe, especially if they are by themselves. And with that, you've just done the majority of your neurologic exam. Now, there are some systemic things that we can add in. I know personally I generally do test neck range of movement. They can demonstrate that for you. Tell them to bring their chin down to their chest. With that, you're testing not only neck flexion, but you're actually able to comment on that there's a lack of nuchal rigidity. You can have them do extension. You can have them look over their shoulder, comment on if any of those movements is triggering headache. And also comment on hypermobility. So if you're worried about a patient with hypermobility syndrome, EDS, Marfan's, you can do the Beighton score, and they're able to demonstrate that for you. So, if they outstretch their arm, how far can they pull their pinky? If they bring their wrist down, can they bring their thumb to their forearm? How much can they extend their elbow, their knee? Can they touch their hands to the ground? So you can do all of that scoring. You're not going to be able to test easily for allodynia, but most patients can tell you, yeah, it is tender here. Actually, it is tender through here. When I touch back here, I get this electric pain that shoots up. So you can have them do that, or they can have a family member do that as well. You can comment on the skin exam. So is it someone coming in and they have pain here and they've got some residual blistering? Well, maybe they've had a shingles that's causing that. Is this someone where they've had a tumor and they've got a scar that you can see across here? Comment on the scar and ask, is that an area where you have allodynia or a tenderness when you touch? Those are all things that you can comment on. Things that you absolutely cannot do. You can't check fundi. There are devices out there to do it, but for a patient at home that you're assessing, it's just not going to be possible. You're not going to be able to do a true assessment of tone, true assessment of reflexes, or your MRC scale, but you should be able to get a really good sense of their neurologic exam for the purposes of most of what we need for a headache exam. Finally, for your patients with a lot of dizziness, unless you're able to do blood pressure to check some orthostatic vitals at home, which I would recommend that you have someone there with them if you're really that worried that you're doing them. You're not going to be able to do the actual vestibular exam. So you can't do a head impulse test. You're not going to be able to do a Dix Hellpike. So those things are going to be a little bit more difficult. Most of the time they're not urgent unless it's something acute where you're worried about a stroke with vestibular symptoms. But in that case, then you should be having them go to the emergency room anyway. You can have them look for some post-head shake nystagmus or have them see if it's harder to read something after shaking their head. But otherwise, yeah, that's one other thing you just absolutely can't do. But the good news is you are going to be able to get most of what you need from your history. And your history is going to be just the same as when you would do it in the clinic. And most of the time, I know what I'm going to be seeing on my exam, so it's not a surprise. So I know if I'm worried and I need to see their fundi. I know if I'm worried and I need to actually check their motor exam. Otherwise, you're going to be able to get a reliable enough exam that you can comment on what you think your patient has, how you should manage them, what investigations are needed. So reassure your patients that you actually feel really comfortable with what you've seen today. Or, you know what, I really need to check the back of your eyes. I'm going to get you in as soon as possible. Or I'm going to send you for some fundus photos at this place that I know is still open right now. And so you do have ways to do all of that. So that's the basics of how you do a telemedicine exam. You're going to need to get creative. It's going to be a little bit awkward at first, but you'll get used to it. Remember that the computer screen is the opposite way, so it's going to feel a little bit weird when you're trying to do some things and where you put your hands. So it takes some practice. You're going to mess it up. That's okay. Your patients are really going to be understanding. They are going to appreciate that you're doing this for them. A lot of our patients will love that they're actually able to do this from home. I know I have patients who drive hours or fly to come see me. And so even once COVID-19 is over, this is going to be a really great resource where we've probably made a huge change and brought headache medicine into the 21st century. This is something, of course, that we're doing because of COVID-19 right now. So I do want to do a plug out there for all the healthcare providers. You guys are doing an amazing job. We'll get through this all together. And in the meantime, we're also going to make sure we take really good care of our headache patients because I know we're capable of doing both. So thank you everyone for all that you're doing.